All right, Jodie, I'm happy to finally nail you down today to talk about this. And actually, this was a perfect time because you've been on my list of people that I want to talk to, but you've recently, put out some very important information about pelvic pain. And kind of think as everybody that listens to this knows, I have a few goals when it comes to this podcast: inform and empower our clients, because I think we need to do a better job of kind of being in the driver's seat of our own healthcare. But then also to keep practitioners up to date on the evidence, because there's always such a lag between what's being done in the research and what we're using in clinical practice, and we're always learners, and or we hope to be. We should be.
We're
This is a
trying.
call to be. And I think that this has been a topic that's been really uncomfortable for people, because it is really different than how, even when I was first practicing as a physio, like when especially Sinead started talking about some of the change in messaging around pelvic pain, I felt uncomfortable based on some of the other messages I had used before. So I love that you can join me today because you've been part of some really important information in an editorial that's recently been released all about pelvic pain in pregnancy. So, Jodie, for everybody that doesn't know who you are, can you tell everybody a little bit about you?
Sure. So my name is Jodie Pulsifer, and I'm a physiotherapist. I work in Vancouver. I wrote a bio, and I hate writing a bio, and I don't know how to talk about myself. So I work in pelvic health. 2 days a week, I rent a space in a midwifery office at Pomegranate Midwives. I also rent a space at Local Health. It's a new, bright, beautiful space, which is so lovely. I work with my colleagues with Full Circle Physiotherapy. We are other pelvic health providers who are all independent providers, but we're networked together with this digital infrastructure. It was kind of this vision that grew out of the pandemic and our shifting ways that we practice to kind of build this infrastructure together. So that's been a fun project for us. And you've had a couple of my colleagues on this before. So Adrienne and Susannah have both been on this. So that's kind of who we are. When I'm not in clinical practice, I am volunteering my time on all these committees and,
Yes.
and working at the association, working with the scope of practice committee, working on the college professional development advisory council, really trying to make systemic change where we can for pelvic health and trying to do better. Our training is challenging, and getting into this area of practice can be really hard. And so figuring out how to kind of support some of that through those governing bodies is another kind of project I'm on. I'm also on a steering committee for Pain BC for their mentorship program, which is a cool program that helps clinicians get better education and better support around pain, addictions, mental health, in an adaptive mentorship model. So it's a free program for any physios listening. It's a free program that you can apply to be mentored, and they'll pair you in a mentorship group for the course of a year. So I'm also in the mentorship group myself, as well as being on the steering committee, because I thought, hey, why, if this is here, could I be a part of this? Because, like you said in the beginning, we're just constantly learning. And so I am just so curious to find more opportunities to learn. So that's kind of me in a bit of a nutshell. I do want to just acknowledge today is September 30th. It is National Day for Truth and Reconciliation. Mel, you've got your orange shirt on, and I think this will be aired later, but because we're here today, and I think this is just a beautiful platform to be able to say it out loud, and to just say the first big part of truth and reconciliation is to learn and speak the truth. I'm a cis white woman. I'm a settler of Mennonite and Amish heritage. I'm a registered physio in pelvic health, and I work on the ancestral and unceded lands of the Hanakwimina and Squamish speaking people. I'm constantly learning to try and say those better, and when I am nervous, they do not come out well. So I apologize for my anglicized way of kind of muddling through those names. Today I think it's really important that we acknowledge the harms of the lives lost. through the legacy of residential schools, and also know that the legacy continues, the legacy of those harms continue. Our systems and our structures today are continue to be built on practices that were not meant to support everyone. I think in women's health we know that really really intimately, and for people who are even further minority groups, they're just at such a disadvantage. And so I think it's really important that we're always aware of kind of the structures that we work within. um, and just again, as we talk today about persistent pain and pain in pregnancy, I think it's really important to recognize that our healthcare training and practice structures continue to perpetuate those provider power and racism, and people's experiences of their bodies can be directly impacted by provider care. So I hope that the discussion today can just shed light on how we can change our practices for people with persistent pain, and that we can learn more about how pain is made, and that can help us learn more about how to open the doors to change it. So, these things kind of all do come full circle with each other. So that's just something that's really important and close to my heart to make sure that we're aware of today.
Yeah, thank you. And I always like to acknowledge too, though, like I also like work and practice just in a different area of the province, but in the Okanagan region. So of the Silex people. And I think at the end of the day, I mean, sometimes we point out, like we honor these certain days, but at the end of the day, we're all the time just acknowledging that everyone's a person, right? And I think that as we talk through this, that will become evident in this specific topic we're talking about, is that everybody's a person, and we always have to acknowledge the life that they have and the individual um, differences that they have, right? And so I want to talk today about a topic that a lot of pregnant women will be able to identify with, which is pelvic girdle pain. And as physiotherapists, we see a lot of these clients, they come in maybe referred by their practitioner or maybe their friend, or they've Googled and they've heard scary terms like my pelvis is out because I'm pregnant. Like the relaxin is making it quite sloppy. My pelvis is sloppy. I have SI joint instability, pubic symphysis dysfunction. Sometimes they've been told not to exercise. I actually had a client come in yesterday and she said, "Oh, I'm bummed because I've been told not to exercise." And I was like, wait a minute. And so those are, I wanted to kind of paint a picture of, and some of these women will be like, "Oh my gosh, yes, 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 I know exactly what you mean. I'm that person, or I was that person." And so today we'll talk a little bit about some of the latest in the research, because I think that there has always been a lot of information around be careful of this. Um, because of this, you shouldn't be doing much movement, and that, it's dangerous. And so I would love for you to talk a little bit about maybe that message, but also to how your team came to put together this recent editorial that you've released.
Yeah, so I mean, the editorial has been my first foray into anything in the research world, and I'm like, oh my gosh, do I want to do a PhD? Took us 10 months to get an editorial put together.
Yes.
So this actually started with my colleague Jess Adaszynski. Jess works in Fraser Health, and she was in the hospital one day and was like, Jodie, do you know any other handouts or anything that's got really contemporary pelvic girdle pain information? I found this handout and it's just terrible. It's so pathologizing and fear-based, and really like restricts movements and tells people to keep their legs together. And you know she's been educated in this and knows that that's maybe not the best approach anymore, but was looking for a patient handout and asked me. And I was like, I haven't seen anything either. Why don't we ask Sinead, who's our colleague in Ontario? And Sinead also works in pelvic health. She's a pelvic health provider. She works at McMaster. She does a lot of training for physios and other medical providers. So reached out to Sinead, and Sinead was like, no, I haven't seen anything, but we should do something about that. And maybe we should do it similar to kind of the way that the back facts had been made. So the back facts was this infographic a few years ago that was made to really kind of debunk some of the myths about just back pain and really get people thinking more broadly about back pain. And so that's kind of how this project got off the ground. And then we sat together and we brainstormed and we pulled in Susannah and Adrienne because we're all together and we're like, okay, what are we going to do here? And we just sat down and brainstormed the problems, and we took, some of the information that Sinead knows from her teaching and the information that Susannah has from her teaching with Rost, and we really kind of like brainstorm different topics and brainstorm different pieces of myths and facts, and modeled it first after the back facts in their entire editorial, and went, you know what, this maybe doesn't work right for this topic. And so then we rewrote it, and it was, I mean, watching us work together was such an amazing process because we just like got to it and teamed up and did different things and really dove into the research. So one of the big things that in going through all of this and trying to make something meaningful for people that is evidence based, but is easy to digest. So, we're looking at the different research and trying to look at the myths that people, typically came into our clinics with, and finding the facts that actually, helped to debunk those if they needed to be debunked, or if they were true, then maybe we would talk about the truth of those things. And so we this wasn't a systematic review. It wasn't a randomized controlled trial, but I have not read so many research articles in such a short period of time to really try and pull things together, and to also make sure that as we put the infographic together, we went back and forth over the words so in such a detailed way, because you have, in the editorial, you have 500 words. And you have to make every single one of those words count. And there is no room for misinterpretation, or hopefully not. And so everything has to count. And on the infographic too, how to distill, we've got these clinical practice guidelines for pelvic girdle pain in pregnancy, the Clinton guidelines. We've got Simmons guidelines for postpartum. And these are like 64-page documents, each of them. And clinically, it's just impossible to sift through all of that. And then at the end of it, you're left kind of going, what am I supposed to do with this? So it was to try and put something together that was just clearer and more easy for clinicians to see the research. Because that's, I think, one of the biggest barriers when you're busy in clinical practice is how to stay on top of the research. And so this was really us trying to take all of that information, standing on the backs of these people who have done the hard work of doing the research, and distilling it in a way that is hopefully meaningful. The infographic right now at this moment is still, it's still maybe a little high level, a little bit too wordy for clients. A lot of clients will understand it and be able to make sense of it, but we still, kind of the next project is maybe to try and figure out how to get some funding to do the next work, because all of this was volunteer work. But to maybe make some type of whiteboard video or something for clients where it's going to be, a really easy click and play to understand, because even this still requires a little bit of more activity to read and try and get through it for clients. So right now we're seeing this more as a clinician research tool, or a tool to share with clients, to go over it with clients to help clients understand it. But we would still like to further that original goal of having something for clients. That was the original start of this project, and we'd love to still see that through, but we're taking a momentary pause.
Well, because it's like so much work, and your mums and your clinicians, and it is so hard to disseminate information, isn't it? It's
power to all the researchers out there.
Yes,
because this It's just amazing to watch the process happen. And we were so lucky, like putting this together. We had a lot of great feedback from the British Journal of Sports Medicine. They were very receptive to it. They worked with us to get the edits to fit the structure of their paper. So they were really, really, excited about it to get it out. So that was an amazing process too, because so often you submit and reject and submit and reject. And we were really, really fortunate that they picked this up and were turned it around really, really quickly. So
Can
that's really exciting.
Yeah, and I actually like I think it's great, you guys, and I actually have it in front of me, which is why I'm looking off of my screen here. And I was thinking like if we could talk about some of the points on here and
Yeah.
just, I think that you make so many good points. I look at one of the very first things you talk about, kind of the pelvis is stable, safe, and pelvic pain is self-manageable. And even just the very first point, I mean, I think we have this vision, or a lot of people have this vision, or maybe we've been told from someone else that when we're pregnant, the relaxin makes us unstable. And, one of the things that you point out in this infographic, I'm going to read this statement here verbatim. The pelvis is resilient and adaptable to the demands of pregnancy, childbirth, and childcare while maintaining its stable structure. Can you
Mhm.
talk about that? Because this is one of the main points, I think, is that you are still stable. Is it different? Yes, during pregnancy, but is it stable? Yes, you'd never be able to get up the stairs if it was unstable.
Totally. Yeah. So I think number one, pelvic girdle pain in pregnancy is really any pain that people experience in their pubic symphysis, in their hips, in their SI joint, in their back. So it's really anything around that whole pelvic ring, all kind of follows under the umbrella of pelvic girdle pain. Even lumbopelvic pain, that low back pain, would still kind of fit in the research, kind of all under that umbrella together. Um, I think pregnancy, people know that it's a time of change and you expect change. And I think sometimes people are willing to put up with pain in pregnancy because they understand their body's changing and they just chalk it up to pregnancy. And so they're willing to kind of suffer through it, as you know. And I think healthcare has said, oh, you're pregnant, just wait till you're not pregnant for this to go away. Wait for, wait to give birth, just wait, it'll go away. We know 30% of people with pelvic girdle pain go on to have persistent pain after pregnancy. So while a lot of people do have spontaneous resolution afterwards, there can be persistence to it. Um, when it comes to some of the myths around the pelvis, that I think one of the biggest ones is that the pelvis is, it's an unstable structure. In physio school, we talked about up slips and down slips and all of these things with the pelvis, and like just the word slip makes
Mhm.
you think that something is like catastrophically wrong. um, the pelvis is a rigid structure. That pubic symphysis, it's a cartilaginous joint. It's there's very little mobility there. It is meant to be flexible, so it's cartilage like your nose, meant to be flexible. But I can bend my nose and I don't break my nose. It's still there
Mhm.
attached to me. The SI joints are if you look at the ligaments of the SI joints, they're incredibly robust. They're incredibly capable. It prevents the sacrum from tilting far. It prevents things from, it allows mobility side to side of the pelvis, but it also prevents things from shearing and slipping and these words that sound so catastrophic. So it is an inherently rigid structure. In pregnancy, there are hormonal changes that allow softening of those structures. It's essential. If you're going to get a watermelon through a bagel hole, you have to you have to have some flexibility there. So those things are necessary. But one of the things we know is that if this was just about the structures, every single person in pregnancy would experience this, because every single person in pregnancy is experiencing structural changes. And because not every single person experiences this, can we blame the structures alone as the source of the problem? And that's really where that biomechanical bias in the past has come from. And what we are really trying to kind of help people learn here is that the pelvis is stable, it is a strong structure, and that pain management can be something that, we all have tools to self-manage and to reduce these signals, and to find capability and strength, and be able to move through pregnancy without fearing these changes. and
Mhm.
and we know that the belief in the possibility of resolution is worth its weight in gold. In terms of people's ability to have success here. And so we really want to ask people what their fears are, what they've got going on with their bodies, so that we can really help them unpack some of those things and give tangible tools and resources to be able to, you know, change some of these sensations.
And I think like that's such a good point. And like I have in the clinic a model, that one model where the pelvis looks quite stiff, like it doesn't have move built into it. Move, that's not the right word, but you know what I mean. It doesn't have any give built into it.
Yeah.
Whereas I have another model that has a lot of give built into it. And so it's all about, I think, sharing that information. Like it's meant to do this. This is a great thing. This is a smart thing that our body does. But like you said, tying in that the brain and the nervous system are also related to that, because the brain and the nervous system sense the change. That's very reactive. And I think that's where you talked about one of the other points that you say on here is that it's safe. Like this is meant to happen. Postural and pelvic structural changes are normal, safe, and necessary to support the growing demands of pregnancy and childbirth. So I say if your pelvis has a little bit more give, that's great. You're normal. Everything's progressing. Um, and then the next point you talk here, it's self-manageable. And I think this is where the nervous system comes in, is that, if you can have some pain education, emotional well-being, sleep optimization, exercise, external supports that promote independence are most helpful strategies to reduce pelvic girdle pain. So let's unpack that, because that's a lot of stuff. And if we go back to, I want to talk a little bit more about exercise in a bit, but can you talk a little bit more then about some of those things? Like why, maybe talk a little bit about the nervous system, like what's going on with the nervous system, and why are we even getting pain then? So what, if the change in the pelvis is normal, then how do we explain the pain?
Yeah. So I think if we go right back, so on the infographic, we've broken it down. So for people who haven't seen it yet, I'm sure you're gonna put the image, and
We
we'll
will.
send you an
Yeah.
image that you can share so people can look at it. But our first category of stable, we talk about hormones, and hormones, joint changes, and varied movements. I think when we're talking about the nervous system, that conversation about hormones is our first critical piece to have, because again, in pregnancy, we think about relaxin, and this is the hormone everybody thinks about, but we're actually talking about the entire endocrine system. And we're talking about stress hormones. We're talking about all, like, sex hormones have changed, all kinds of different hormones are changing on every different axis. In pregnancy, we are designed to keep ourselves safe and keep our babies safe by being more alert to the signals in the world. So, before I even peed on a stick and knew I was pregnant, I could feel myself huffing and puffing. I could feel changes were already happening. You're not just a little bit pregnant. You either are pregnant or you aren't pregnant. And in those early days in pregnancy, your entire system is already adapting to trying to be pregnant, to hold a pregnancy, to keep a pregnancy. Um, and so the nervous system is changing. The nervous system goes on high alert. I had to change you walk into a room and you can smell everybody, and
Mhm.
the right. So that's an output of the nervous system starting to become more alert, is that now we smell more acutely, we taste or don't like things. There are maybe in your sleep at night now you're having wild vivid dreams or things. I met some old sexual partners in my dreams in pregnant. You're like, what is happening inside of my body here? That's what we're talking about when we're talking about the nervous system shifting, is that there are all of these extra signals that are happening in your body to make sure that you can be on alert for danger. You want to make sure there's no lion coming into your den. You want to keep yourself safe. So your whole system starts scanning for dangers a little bit more, and that is us scanning for dangers in the outside world, but it also is scanning for dangers inside of our body. So some of the signals that are coming from inside and outside come in a little bit hotter, a little bit faster, and a little bit more fiery. It doesn't mean that they're dangerous, but it's drawing our attention to them. It's drawing our attention to the change, and it's asking for us to do something. So that's really when we're talking about the nervous system. It's not just something that we think away. It is this entire body experience that is happening, where the signals and communications from the periphery and the central system are interacting with each other in a much more alert system.
That makes complete sense. And then like this, just that our bodies scanning, like you said, more robustly. But then will you talk a little bit too about, because I think we always tie, like you said, it's not just relaxin that's at play here. We're looking at so many things. You talk a little bit about how there's actually no evidence that correlates relaxin levels with pelvic pain. So I think that's a really big thing. People will say, what? That
Yeah.
everybody has that belief.
Yeah. So relaxin is actually often highest in first trimester. And people tend to experience pregnant or pelvic girdle pain more often in kind of transition between second and third trimester. So, we blame relaxin. Oh, the relaxin's getting bigger as it prepares for birth, or relaxin, relaxin, relaxin. You're like, actually, it was highest in first trimester.
It's
So
dropping. Yeah.
it's dropping, it's changing. Estrogen is climbing to the end. So it's just become this word that's got thrown under the bus. I think, yes, hormones are changing in pregnancy. But I think just putting one thing on it with anything with pain. Pain is a physical and emotional experience. It's a learned experience. It's a practiced experience. One of the conversations on pain science right now that is really interesting is talking about prediction error. And when our brain thinks something is going to happen and it doesn't happen like that, perhaps that's where that alert signal comes in. And if we don't know what's happening, then maybe it comes in as a pain signal. We interpret it as painful so that we really pay attention to it. Perhaps that's where pain is happening. So that can absolutely be happening when we take steps, or, when in with pelvic girdle pain, for a lot of people, it's rolling in bed, it's standing on one leg to put their pants on, it's going up and down stairs, it's making transitional movements. A lot of those can be quite uncomfortable. And is it because of a biomechanical thing, or is it because the body thinks this transition should feel like this, and when we go to make that transition it didn't feel like that, and the body's like, wait, that was weird, and so we get this signal. So that's talking about prediction error, and that sense of interoception and proprioception, and the confusion that the brain and the body are having around how we're interpreting those body movements. So that's where we're thinking maybe pain is coming from. These are all, our constructs of pain and our constructs of our body are still evolving. This editorial and this infographic is what we know of the research now. It's going to continue to evolve, and we're going to continue to get more insights. So we're debunking some of the myths that we have evidence to debunk with right now. We still are going to learn more about pain, and we are still going to learn more about pelvic girdle pain in pregnancy. And maybe we'll need to update this and change it. Or maybe there will be a magic strategy that if we just, take a pill. I don't anticipate that that's going to be something that we're going to find, because, I think the research is really moving us into a more lifestyle and more holistic look at people and their experiences, and really looking to see, if you're not sleeping well. We already talked about the nervous system being more elevated just simply by being pregnant. Now compound that by not sleeping well. Maybe you're not sleeping well because your job is stressful. Maybe you're not sleeping well because you have a toddler at home. There's a variety of reasons why people might not be getting a good night's sleep. When we're not sleeping well, those signals get a little more alert as well. We need restful sleep to have our system be nice and quiet and relaxed. So when we talk about management strategies, talking about managing sleep as an option, and now recognizing as well that we can't all get a full night's sleep. I still have a child who comes into my bed every night. I can't change all of these features, but what I can do is acknowledge that some of my signals are maybe a little bit different right now. And so I have a better understanding of why my signals might be a little bit higher. so that I'm not worried about those signals, that I'm not afraid of rolling over. And maybe we're going to work on optimizing the sleep windows that we are getting. Maybe we're going to get a cell phone out of the bedroom, or put some earplugs in, or something, just to get a slightly deeper sleep pattern so that those signals could get a little quieter. So those are some of the things that when we talk about lifestyle management, it's looking really really holistically at people and what's going on to try and quiet the nervous system. When we think about the other things in kind of the infographic to exercise and varied movements, we know that exercise helps to keep the signals happy. It helps to keep the body from guessing. It helps to keep us resilient and strong. We used to tell people with pelvic girdle pain to keep their legs together and to just, sandwich your legs together and slide in and out of the car. And, how do you walk if you keep your legs together? Are you going to hop like a kangaroo? Like, it's a completely impractical thing to do. And we would never train an athlete or ask an athlete to have just 4 or 5 movement patterns and think that they were going to be resilient and injury free. The more varied we can create movement patterns, the happier those joints become, the happier those signals are in the biomechanical system, because the brain is learning the changes. It's able to then not have those prediction errors, and it's able to just feel more comfortable. Maybe that also is the strategy to have better sleep, is that we're getting physical activity. So now we're tired for the end of the day and we have deeper, fuller sleep. So all of these kind of features interplay with each other. So it's not just one little strategy being successful, and it's looking with people on all of the things that they've got going on and saying, where are we going to get the most value added for you? Which one of these things do you think you might want to tackle? What feels important to you to kind of take forward? Is it, sometimes just pain education is enough for somebody to realize, oh, thank goodness I'm not going to fall apart. Like, thank goodness my pelvis is stable. Oh, I didn't realize the fact that I can stand means my pelvis is stable, right? If that SI joint and that pubic symphysis are not stable, you could not be an upright human being. It is such a stable structure. So sometimes that pain education with clients in my treatment room, sometimes that's all they need is is just to learn that piece of information and to have freedom to take longer steps. And all of a sudden, a week later, things can feel dramatically different.
I
So
I have this
it's
person up.
complicated and convoluted, but it's also can be really simple sometimes.
Well, and I think about, like, if we were to think about some individual people, I think of this one lady, like I said, that came in yesterday. I want to say halfway through her pregnancy, and she, very active person, but nothing that involved, like, she liked to hill walk. She liked to do some different hit style exercises, and she was getting quite a bit of pubic symphysis pain, and was told just stop hill walking and walk flat. But then we talked about it. We were able to do some of the education. She's like, oh, that makes sense. That makes sense. You could just see the fear leave her body.
Mhm.
And then I want to talk a little bit about pregnancy support belts, but I showed her how a belt can be very helpful. I said, this is not going to stop your pelvis from moving. This will not stop your muscles from working, but it's like wearing a knee brace for tennis. Like, I'm going to give you some exercises and some things to think about, but put this on if it feels good when you're walking or what have you. She put it on and she's like, this feels great. I'm like, well, then it sounds like it's a good option for you. But then we talked about how, like, I got her to think about some different muscles around her pelvis. Like, she was having a lot of tension with some of the muscles that were like her groin muscles, and she was pretty weak in some of her glute muscles. And so she was able, by bringing attention to those, she was able to find ways to move with more confidence. She's like, oh, well, if I just kind of think about my glutes, I don't have the pain. If I think about, instead of rolling over and kind of, she said, I notice I'm kind of anticipating that pain. Whereas if I think about a little bit of a glute squeeze, or I just let my brain relax into it, oh my gosh, it didn't hurt as much. And then we talked about how, no, absolutely, you should keep walking, but maybe think about it a bit differently. Instead of, like, she was noticing, she was using, like, she wasn't using her glutes when she was walking up the hill. So she noticed that if she thought about it differently, she had the confidence to do it. So all I'm saying is with her, we didn't talk about sleep because actually she was a first time mom and I could tell she didn't feel sleep deprived. But in a client earlier in the day, this lady came in looking tired. And so we talked a little bit more about having time to sleep and not maybe exercising as much that day. So I think I'm trying to bring out that it's not going to be the same recipe for every single person. But this is why I think this infographic is so helpful, is so that you can start like, well, there's so many things that I can talk about to help them make a positive change, right?
Yeah. And knowing where people's fears are, right? Like,
Yes.
so if somebody's worried, or they're thinking it's a hormone related thing, and then they're worried postpartum that if I keep breastfeeding, I'm going to keep my hormones in this altered state. Maybe I should stop breastfeeding because of the hormones so that I get back to my more normal hormone level. And so if that's something that somebody is worried about, then we have good evidence to talk to them about the fact that breastfeeding is maybe even protective against pelvic girdle pain. It does not make it worse, and perhaps even protective. And we don't know what the protective mechanisms are. Is it the happy hormones that you get if you're feeling happy breastfeeding? If you hate breastfeeding, maybe it's not the thing that you want to keep doing. Um, but being able to talk to somebody again about if it's important to you to keep doing this thing, we have good evidence that this is not going to create more challenges for you around your pelvic girdle pain. The same thing with vaginal delivery. If people are thinking about vaginal delivery and they are worried about, is my pain going to get in the way of my delivery? Am I going to not be able to birth vaginally? Sometimes people are worried, oh my gosh, I have pelvic girdle pain. My pelvis is small, and now I'm not going to be able to birth vaginally. And again, we have evidence to support that birthing vaginally, if that is something that people are interested in doing and feeling safe doing, can again reduce the risk of prolonged pelvic girdle pain. So if, we are not, again, saying don't have a C-section, if a C-section is the thing that makes you feel safest and feels the most supported, we want you to also be able to have choice around that and agency around that. But if you're thinking about a C-section because you're worried a vaginal delivery will make your pain worse, then we want to be able to educate you that you have choice and agency here, and it won't make the pelvic girdle pain worse, and it doesn't need to get in the way of vaginal delivery. So those are kind of, again, in our safe category. We want to make sure that people know if there are things they're worried about, that we have good evidence to tell them that there's safety in some of those things. There's safety in posture adaptations, there's safety in lactation, there's safety in vaginal delivery. And then when it comes to the self-management, again, so many opportunities for change and so many opportunities to kind of tap into things. I teach a course with Carolyn Van Dyken on sensory motor change, and learning about that system and how our brain and our body's representation of ourselves is interesting and not always accurate. That, again, I think in pregnancy and pelvic girdle pain may be contributing to some of these things. Sensory motor representation is how we perceive ourselves, and we can perceive ourselves beyond ourselves as well. So, like, if you're in a parking garage and you drive into a parking garage and it feels too short and you're sitting in your car and you duck, you're never going to make your parking garage, you're never going to make the car smaller by ducking, but you've created this image of your entire body that is now beyond your body because you're operating a car. And so you're changing things because of that. So that's how our brain gets these things sometimes distorted and sometimes a little bit funny. And so, again, with pelvic girdle pain, maybe there's some of that contributing in here. And by doing things that are varied movement, that help your body re-identify, okay, this is the space that I occupy. These are the things that I can do. I can step further. I can take all these things, like your client thinking about even engaging her glutes. That visual imagery taps into that sensory motor system and allows her to fire things that maybe she wasn't firing as accurately because she's brought some mental awareness to it. And that it can be really, really helpful in those transitions. And that's where Rost and other manual therapy techniques can be really, really helpful, like the belt as well. is that it can give you new feedback and allow you to do some of those things that you otherwise might have anticipated could have been challenging or were afraid of doing. And we want to, again, use those tools to help people take back those lifestyle things. The ultimate goal is that people can move in their lives, that they can take care of their children, that they can go to work and do the things that are important to them. So all of our treatments and all of our strategies have to always come back to our client and what's important to them, what has their pelvic girdle pain stopped them from doing, and how can we use the tools in our tool bag to get them back to some of those things and understand, again, that they're not falling apart. This doesn't have to last forever. You don't have to live with this till the end of pregnancy. One of the first things that happens, if you've had it in your first pregnancy and now you're pregnant again and you've got a toddler at home and you start experiencing this again, what's the story that goes in your head? I know for me, you're like, oh shit, like this is happening at 15 weeks this time, and I've got so much longer to go. I've got 25 more weeks to go. How am I going to get to the end of my pregnancy? So there's that anticipatory and fear driven kind of anticipation. Now your body's going to protect. Now your body is going to start to take some of those guarding patterns. And so we want to break that cycle really early for people. We want to give them tools and skills to manage that so that they are like, okay, by 20 weeks, they're feeling good. They can exercise. They can take care of their life and feel good without having to kind of dread that and anticipate the worsening for 25 more weeks.
Yeah, because like you said, it's so much about the nervous system. An analogy I always use, because I'll say I describe all this stuff and just show them what's happening with your pelvis, you're normal. But then when we talk about how anticipatory the nervous system can be, and I say, picture, often they have a toddler. Picture you and another mom are walking down the street with your toddlers and they both wipe out. And you can see they're not really hurt, but they're both wailing. One mom goes over and is like, oh my God, band-aids, band-aids, let's go for an x-ray. Oh, baby, let's go home. Whereas the other mom's like, look at the birdie, look at the puppy, and distracts the child. Which child is more likely to throw more tantrums? And they're always like, oh, the first one for sure. And I say, that's exactly what our nervous system's like. And pelvic pain is often like, is that if that movement is always painful, or if you're kind of like, oh my gosh, this is going to hurt so bad, then yeah, you'll get a tantrum or you'll get like an overreaction. Whereas if you can sometimes I describe the glute strengthening as a distraction, or maybe they use a breath strategy, or I say sometimes just think about something else and just try some different things, because quite often it's the same as the tantruming child.
Yeah,
Right?
we're bringing. I think a lot of it is you're bringing awareness to it without fear, and you're bringing awareness to it, going, "Thank you for these signals."
Mm-hmm.
You're like, "Yep, I am aware. Maybe I didn't move for a while, and so now I have
Mm-hmm.
some signals that I was ignoring. Now I'm present to them. I'm going to move my body. If those signals dissipate." That's awesome. That's exactly what that response system is supposed to do. We're supposed to be cued to move more, and when we do some of those things, those signals get better. Again, with pelvic girdle pain, a lot of times people experience these signals, but then they go for a walk and walking eases it. Maybe they walk for a long time and now it's worse again. But there's this fine line that movement does kind of ease things and quiet things. So we want people to have that. I think it's really important as clinicians that, in our understanding of a biopsychosocial model, um, a biopsychosocial model means biology, psychology, and our social constructs are all interplaying all of the time. When we were originally taught this, I remember seeing this, Venn diagram where there's three circles and they overlap, and there's just this little bit of crossover between the three circles. And so you can really see how clinicians, if that's how they were trained, would treat the bio as if it's its own little thing, and treat the psycho if it's own little thing, and treat the social as if it's its own little thing, and that there's only these small overlapping areas. It's not like that. It's three-dimensional, it's spherical, they're all blobbed together. We can't separate them out from each other. Just like those children falling down, there was biology there. There's probably cuts and scrapes and things. There is true tissue changes happening there. But the culture and the social constructs of how a parent conceived that pain experience is going to change how they perceive that pain experience. I was teaching when my daughter was learning to bike, she wiped out, and I taught her to say, I bailed hard and ate dirt. You're like, yeah, because I wanted to applaud that experience, that this,
Mhm.
in our family, wiping out and having an injury is a growth opportunity,
Mhm.
not a danger opportunity. In another family, that may be
Mhm.
perceived as a danger opportunity. So it's looking again at some of those constructs and understanding biology is here, and all of these other elements are here too. So it's not saying there's no biological changes. There are 100% biology changes. There are 100% biomechanical changes. You're growing a baby in front of your body. There is a massive
Mhm.
biomechanical change that is happening. Um, but it's also really important that clinicians, as we move from just thinking bio, that we don't just pathologize the psychosocial elements either. Sometimes I think clinicians learn these tools and then really are just like, oh, you're stressed, you need to deal with your stress, and then that's it. And we don't give people other strategies. We need to give people strategies in the moment to change some of those sensations. Maybe people can't change their stress. Maybe they're in an environment that is not modifiable. Perhaps somebody is unhoused. Perhaps somebody is, we've had a lot of war, immigration happening. We cannot change those stressful things that are happening for people, but we can acknowledge that those stressful things may be making the signals bigger. And then we want to find them a strategy of something they can do about it. So that's where things like symmetry from Rost are beautiful, because it can be a really lovely opportunity for somebody to learn how to change those signals. When I do manual therapy for most of my pelvic girdle pain clients, with them understanding how the system is interplaying. And then we'll get them to do some butterfly and bridge and do that symmetry cycle. If I'm treating virtually, we're just doing it virtually and teaching somebody how to do it on their own. And after they do that sequence, if they feel better, boom, we have given them an opportunity to change their pain. They feel super confident and empowered by it. We give them the opportunity to do that with some regularity to chase away those signals. And now their body has learned rolling is okay, standing up is okay, walking is okay. And now you walk through the rest of your pregnancy. Now you keep doing those things. So the same thing with belts, right? We have evidence that belts are helpful as an adjunct. The problem is, again, I work with midwives and they're strapped for time. They don't have all of this information. They want to be able to give somebody a tool. And so they say, okay, you can use this, it'll help your pelvis to be stable. And then you put on this belt and you think, if your fear was that your pelvis is going to fall apart, and now you have a belt that is holding, I'm air quoting here, holding your pelvis together, that cycle by itself without better explanation is going to potentially pathologize the pelvis further. But a belt used the way that you said, Mel, if this makes you feel better and allows you to walk more, sometime with it on, sometime with it off, that's a great opportunity. We hope that you don't need to use the belt always. We hope that this is something that, just gets you going. And once you're going, you may not need it anymore. If you like how it feels, that's great. You can keep using it, but it's not because it's holding your pelvis together or fixing you, again, air quotes. Um, but it is really helping you to take back some of those things that you weren't able to do because of the pain.
And something that's coming up as you talk is I think that, again, people are looking for black and white, and we're talking about all shades of gray here, and it's just another option. And I think that people will be listening to this episode thinking like, are they going to tell me if yoga is okay? Or are they going to tell me if strength training is okay? And that I can pretty well guarantee that what you've taken out of this with the point varied movement is that it kind of depends. And I think there's a lot of messaging around there. Don't do yoga in pregnancy because you have this laxity in your pelvis, or don't do strength training because it's too much loading on your pelvis. But at the end of the day, variation is great. But if yoga doesn't feel good, then it's probably not the right thing for you. If strength training feels amazing, then how do we argue with that? So I think that as people listen to this, I think that is another take home that we have, is it's just another tool. All of these are just ideas. And I think sometimes it helps for us as clinicians. I'm a terrible drawer, but I'm good at drawing these like spider webs where I'll say, okay, you have pain. Here's like 20 options I could write out. We could talk about what interests you, because maybe you can't afford a belt. That's
Yeah.
okay. Let's
Yeah.
talk about something else. Like,
Yeah.
let's pick the low hanging fruit here.
Yeah.
But
Yeah.
yeah,
That's exactly it. And I think, again, um, manual therapy is a wonderful technique if it makes you feel better and gets you to take back things. I'll always say to people, I'm happy to give your system a touch-based approach if that helps you to, do all those other things. But what I don't want you to feel is that you have to come to me for this. If you want, I go for massage. I love passive therapies. I love passive therapies for myself. I go for massage, and it is a wonderful moment where I get to put things on pause. I get to evoke the relaxation response. Somebody is loving on my body for an hour, and that is a wonderful experience. Am I getting tissue changes from the massage itself? Is it all wrapped up in the whole experience? I have no idea, but it feels good and it makes me able to run and do my sports and all of those things amongst all those other things. Can I skip it? Yeah. Can I skip relaxation? No. So we have to have these opportunities to push pause. We have to have opportunities to get cardiovascular fitness. We have to have opportunities to have sleep. All of those things are life non-negotiables, but how we access those life non-negotiables can be very different for each person. And so it's giving people, maybe it's a qigong practice, maybe it is the yoga practice, maybe it is going for a massage. All of those things are opportunities to tap into how your body is going to make sense of the signals and to feel good and move forward. So we're not pathologizing or demonizing any of these strategies, but it's making sure people understand a bit more nuance of why maybe those things are working without concreteness, because we don't have concreteness in the evidence. We don't have concreteness in these questions, and we don't have concreteness as to why those things are effective. We know that they're effective, but we don't exactly know why. And do we need to know why if it makes us feel better and we can take back life?
yes, I love that you bring that up, because that's definitely something that I wanted to ask you about, because I know that like I have a lot of clients that come in and they'll say, well, let me just back this up and say, because correct me if I'm wrong, but the research the evidence shows that pelvic pain, like the indicators for the highest, I'm not saying this right, Jodie. So pelvic pain is highest when for people that have more stress. They don't sleep as well. They don't have job satisfaction. Like, those are some of the biggest predictors, I should say, of pelvic pain. Not
Yeah,
necessarily like
past
the right side of
injury.
your pelvis is higher than the other, but that more, I guess, showing more upregulation in the nervous system. Those were the factors that indicate higher levels of pelvic pain, correct? But so I think all I'm trying to get at here is that I think sometimes people like, my right side of my pelvis is higher and that's why I have pain, or I need to go see someone regularly to put my pelvis in place, or I'm going to have pain. We're trying to say that hands-on therapy can be very helpful, but what exactly is at play there? Is it helping to down train your nervous system? Is it helping your body feel better? Is it making you feel that you have a solution, like that you have something? Is it giving you hope? But pure hands-on therapy might not address all of the symptoms because of the other indicators that say that that's why the pelvic pain's high.
Yeah, and I think too, hands-on treatment, I mean, in the Canadian model, is expensive, right?
Yeah.
You have to have a job and have benefits. to be able to afford these allied health services. My services are the same. People have to have extended health benefits to cover it, or they have to have a job that pays them enough to be able to pay out of pocket. These are very expensive services. And again, the research doesn't point us towards having to require those services in order to change our pain. There are opportunities to change pain, again, most importantly, through lifestyle interventions, through quality sleep, through physical activity, through stress and emotional well-being. Those big critical factors will quiet down the signals, and addressing fear and helping people get going are the best ways. That is where the evidence, that's number one, where we need to start. Manual therapy and external supports are supported strategies. They're not off the table. And for a lot of people, it feels really good to go and feel supported and to be heard too, right? Sometimes it's just being in a clinic and having somebody hear this, validate it, and be there with you. That also is worth its weight in gold for some people. So it's just saying that manual therapy may not be just about the manual techniques. It may be more about a variety of other features. And ultimately, when we're talking about pain, we're talking about sensory motor representation. We're talking about the possibility of prediction error, that your brain and your body are trying to make sense of the new signals, and maybe we guessed wrong. And so your body is giving you extra alert to pay attention. But hurt and harm are not the same thing. And we really need to help people tease out that something might be uncomfortable, but it's not dangerous, and especially as we head towards thinking about the possibility of labor and delivery. Ooh, talk about hurt and harm in that scenario, right? We want people to understand good pain science. We have good evidence that supporting people to understand pain science as they head towards labor and delivery is also helpful for coping. Sinead's doing research on on this kind of thing using I think they're using an app to teach people about pain science as they prepare for labor and delivery. So, also teaching people about pain science when they experience pelvic girdle pain in pregnancy. This is an amazing opportunity we have to teach people about the opportunity to experience discomfort and to be able to find opportunities to move and novel ways to move and to improve their pain experience. That can be incredibly powerful as people go towards birth and feel like, I know how to change things. I have a good construct of pain. I understand that the sensation of pressure can be incredibly intense, but it can be a pain positive experience in labor and delivery as well. And so, again, we've got this opportunity in pregnancy. If somebody comes in with pelvic girdle pain, I am like, yes, we can do this, we can change this, how exciting, and give you so many tools to be able to change your experience as you go through pregnancy and as you go through delivery and as you go through postpartum as well. So we really have this beautiful window, if somebody ends up in my care, to be able to help them learn more about this experience and to give them tools to help themselves all the way through all of those transitions.
Well, in the bold letters on the front of your infographic, the strongest predictor of resolution of pregnancy related pelvic girdle pain is having the belief it will get better.
Yeah. Yeah.
Right.
Yeah.
And I think that's such a powerful to see that. And that's exactly what we tell people to prepare for birth too, is like, this too shall pass, or, to be able to
Whatever
focus on that,
mantras you
whatever
need
you
to
have.
help.
Yes.
And yeah.
So if we were to tie this up with kind of a parting message, and to make sure, like, this is going to make some people's brains hurt, or is this going to make you mad? Some of you that are kind of like, well, no, this is not what I'm hearing, or this is not what I believe, is just sit with it. But I think, if you are a practitioner that is still like, whoa, this is very different than I thought, like I said, sit with it and then come back and listen again. And just, we are, go easy on yourself. We are all learning, and you're listening, so you're open to it. So clients that are listening, that are still, hearing some of those messages that your pelvis is out, or you have SI joint instability, you have pubic symphysis dysfunction, your pelvis has laxity. I would like take that with a grain of salt. And it's okay to share this episode with your care provider, but also too, there's no two providers the same, and work with someone that makes you feel positive and helps you incorporate everything and helps you work in a way that sits well with you and your nervous system. Anything else, Jodie? What other parting messages do
Yeah,
you
I
have?
mean, I think, number one, your sensations are real. Pelvic girdle pain hurts like a that's me bleeping myself out. I have
Thank you for
experienced
doing that
pelvic
for
girdle
me.
pain. I struggled with it in my first pregnancy. It felt like my leg was going to fall off. It really, standing on one leg, it really hurt. So we are not saying those
Mm-hmm.
sensations are not real. Those are real and really, really impactful. But these are changeable, and we have lots of tools and lots of arsenal to help you change your pain. You can change your own pain. You can, again, take longer steps, find different ways to move, explore all the possibilities of movement, not just, check your pain, check your pain, check your pain. Check all the things that are pain free. Find all the other ways to move that are pain free, and then come back to those, more challenging movements and see if those haven't gotten better. Look at sleep, look at kind of some of those other factors going on in your life, and see if maybe those just might be reasons the signals are coming in a little hot for your body, so that you can feel like you are, understand why they're coming in, but not that they're causing harm, but that they're coming in and they are real. And then if you are needing help beyond those things, then look for a provider who does treat pelvic girdle pain in pregnancy. For a lot of people, that is pelvic floor physios, just simply because we're treating in pregnancy, and we're also, we just as a group have a lot of knowledge about this. But if you're not getting better with a provider that you are seeing, there are more providers and there are more options. And so it's okay. It doesn't mean that that provider was doing something wrong, but perhaps it just wasn't the right fit for you. And so it's okay. We all know that we treat a bit differently as healthcare providers. It's a challenge. You want to walk into an office and think that we're all the same. I get it. I feel the same. I struggle to find healthcare providers that are the right fit for me. It takes a bit of work, but it's okay to kind of try a few on if you're not getting what you need. um, but then as healthcare providers too, give your clients permission to go somewhere else if they're not getting what they need. Don't hold on to them if you don't feel capable of changing, or if you don't feel like you have these skills. Let your clients know with full transparency, I'm new, I'm just learning this skill. If you want to keep working with me, great. And if we're not able to get you where you want to go, I'll try and give you some names for some other people. Be fully open and transparent, because that builds trust with your patient. And when your patient trusts you, they're going to be more successful with you. So we want to build those relationships of trust together, so that patients feel like they're in the best hands. Because again, that belief in success is again just so valuable. So we want to create those things for people.
Nailed it, Jodie. Listen, I really thank you, because I know this is another thing that goes into your bank of things that you do on your own time. So I know your passion, and I know you love to share good quality information and help not only patients but other practitioners. So thank you for all that you
You.
do.
Great. If anybody listening has a magic pool of resources to turn this into a a patient thing, reach out, find me. That's my
Yes.
other shameless plug for
Oh, please. Like,
supporting knowledge translation. It is a challenging task. And so we really
mhm.
appreciate having the platform here, Mel, so that we can share it. And again, just try and spread the message that this is changeable and we've got lots of opportunities here.
Absolutely. And I look forward to linking a bunch of those resources, and obviously your editorial with the infographics in the show notes. So thanks again, Jodie.
Yeah, it's my pleasure.